Today I am going to discuss with you the history of a 65-year-old man who presented to the emergency department with complaints of severe prolonged cardiac pain and shortness of breath. He was diagnosed to be having acute myocardial infarction as ECG showed ST segment elevation and had features of LV dysfunction. That explained the breathlessness. He has history of hypertension and has been taking antihypertensive ACE inhibitors. On examination, his blood pressure was 90/60, heart rate is 110 per minute, and he was profusely sweating. His urine output during the last 6 hours was 60 ml. His body weight 50 kg. Any patient coming to the emergency department, you should always look for whether a patient has got features of or patient is developing acute kidney injury. Has this patient got acute kidney injury? As per the critical criteria, acute kidney injury can be considered if the serum creatinine rises 0.3 mg per deciliter or more within 48 hours. So if the baseline value is not known, you take the creatinine and repeat the creatinine. And if the creatinine is rising, it indicates acute kidney injury. Second is increase in serum creatinine 1.5 times or more than the baseline of the previous 7 days. If you know the previous value during the last 7 days, and if the creatinine is 1.5 times more, we can definitely say the patient has developed acute kidney injury. And the simple bedside method is looking for urine volume. If the urine output is less than 0.5 ml per kilogram for the last 6 hours, we can say the patient has got acute kidney injury. The term acute renal failure is replaced by the term acute kidney injury now. So this patient's weight is 50 kilograms. So during the last 6 hours, he should have passed 50 into 0.6 into 6, that is 180 ml. Here the output is only 60 ml. So definitely you can say the patient is having acute kidney injury. The point number 1 to be remembered is that anybody coming to the emergency, we should always look for the patient has got evidence of acute kidney injury. So the question is, this patient is likely to have, this 65-year-old patient is likely to have what type of acute kidney injury? The options are pre-renal, renal, post-renal, or the patient has got a chronic kidney disease. The correct answer is patient is having pre-renal acute kidney injury. Why do you say it is pre-renal? Acute kidney injury you divide into pre-renal, that is causes before the kidney. It is most often due to hypoperfusion, due to hypovolemia or other causes. Second is the renal cause. Renal cause means it is a disease of the kidney that is producing the renal failure. That is a post-renal, that is obstruction to the, it is otherwise called obstructive uropathy. Or this patient has got a chronic kidney disease. We often divide kidney disease into acute kidney injury and chronic kidney injury. Acute kidney injury means the renal dysfunction occurred over hours, days or weeks. Whereas chronic kidney disease, there is irreversible damage and has produced dysfunction, that is renal dysfunction, that is persistent for at least 3 months. So here most likely we can say that the patient is having a pre-renal acute kidney injury because patient had hypotension. That explains the pre-renal cause. So hypotension leading on to a temporary or acute damage or acute failure of the kidney or acute injury to the kidney, you can say it is a pre-renal acute kidney injury. But the problem to be kept in mind, many patients may be having a chronic kidney disease. Especially this patient, an elderly person, patient is having hypertension, so he can have an underlying chronic kidney disease also. So remember this point, acute on chronic disease. That is a patient with acute kidney injury can lead on to chronic kidney disease. At the same time, a patient with chronic kidney disease can develop acute insults and produce acute kidney injury also. So this is a second concept you should remember. There can be acute on chronic kidney disease. So here take this patient. What are the risk factors for this patient to develop acute kidney injury? First and foremost is age of the patient. What is the importance of age? The physiological changes occurring in the nephrons, there is a decrease in the number of nephrons as age advances. The GFR falls progressively. So many older patients will have established chronic kidney disease by the time they come to the casualty, or when they are coming for some other problem, they have got a CKD. So acute decline in the renal function interfere and further produce significant impact in the kidney function. So physiological dysfunction leading on to decrease in the nephron number. Second is creatinine depends upon the muscle mass. As age advances, muscle mass comes down, less creatinine is produced, and so serum creatinine cannot be taken as a definite measure of renal function because it will underestimate the severity of renal failure. Third is the renal tubular functions. As age advances, renal tubular function declines. This leads on to loss of urinary concentrating ability. So again, this can lead on to a small insult can aggravate the problems. Fourth is drugs. Many patients are on prescription drugs and non-prescription drugs. Drugs like diuretics, ACE inhibitors, NSAIDs. They can produce kidney damage and they may attribute to or increase the risk of acute kidney injury. Next is the infection. The patient has got a prostatic obstruction, elderly can have multiple myeloma, severe cardiac dysfunction, hypertension, all are common, and this may again aggravate the or predispose the patient to acute kidney injury. And as age advances, because of these comorbid conditions, patient can develop or the patient can have got more mortality. So we have discussed the importance of age. Second is hypertension. I already mentioned hypertension can lead on to renal disease. Second, renal disease can produce hypertension. Medications we have explained. The most important thing is ACE inhibitor. ACE inhibitors preferentially produces dilation of the efferent arteriole. So already the patient is having hypertension. ACE inhibitors will further produces a dilation of the efferent arteriole and filtration pressure comes down. And if the patient is on NSAIDs, what happens? NSAIDs inhibit the prostaglandins. Prostaglandins preferentially dilates the afferent arterioles. So when the afferent arterioles are, the prostaglandins are not there, they constrict and glomerular filtration comes down. So that is the importance of giving NSAIDs to patients with acute problem. Or somebody admitted with hypertension, you give NSAIDs, it can precipitate acute kidney injury. Already I have discussed the pre-existing kidney disease like pre-existing CKD predispose the patient to acute kidney injury. So we have discussed the important predisposing conditions, and the most common cause for acute kidney injury, pre-renal cause, is volume loss. So any condition that produces hypertension. So we will discuss these things at a later time. Now the question is, what are the early signs of intravascular volume depletion when you are suspecting pre-renal acute kidney injury? Options are A. Bradycardia and post-hypertension. Of course, whenever there is hypertension, you will not get bradycardia, so that option is wrong. Tachycardia and post-hypertension. Any patient with post hypertension and tachycardia, you should consider the possibility of a. So the correct answer is tachycardia and post hypertension. So point to be kept in mind. When a patient has come to the casualty, you suspect volume loss. If the BP is normal, make the patient stand up and record the blood pressure. If the BP is already low, there is no need to check or look for post hypertension. So it's mandatory, especially if somebody comes with the upper GI bleed. Make the patient stand up and they record the BP if the BP is already normal. 20 millimeters systolic, 10 millimeter diastolic fall is significant post hypertension. The next question, which condition may be indicated by warm peripheries and hypotension in a pre-renal acute kidney injury? So when there is a hypotension, perfusion comes down and you expect a cold extremities. But suppose you get a warm extremities, the correct answer here is, different options are given, the correct answer is sepsis. Sepsis produces vasodilation. So this will produce a pre-renal type of failure because there is a decreased perfusion to the kidneys and the extremities will be warm. So warm extremities and has got hypotension think about sepsis. What may indicate hypovolemia in pre-renal acute kidney injury? Clinical examination, what are things? The options are given. So the correct answer is cold extremities and delayed capillary perfusion. So these are the two tests that you should do when somebody has hypertension. Look at the extremities whether they are cold and look for capillary refill time. More than 2 seconds indicates there is a significant peripheral circulation inadequacy is there. So concealed blood loss can occur in pre-renal acute kidney injury, and delayed capillary return and cold extremities are signs of poor peripheral perfusion. And when there is a hypotension, the hormonal activation occurs. The question is, which system is activated in pre-renal acute kidney injury to promote sodium retention and systemic vasoconstriction? That is, when there is hypotension, you have to increase the volume and increase the blood pressure. Correct answer, of course, is renin, angiotensin, aldosterone system. The antidiuretic hormone is also secreted, but the predominant protection occurs by renin, angiotensin, aldosterone system. So next question is, what investigation may reflect activation of this hormonal system due to intravascular volume depletion in pre-renal acute kidney injury? So when there is a pre-renal acute kidney injury, this renin angiotensin system is activated. This will produce reabsorption of sodium, and this leads on to decrease in the urinary sodium. So decrease in the urinary sodium is a definite evidence of activation of the renin angiotensin system. In addition, aldosterone will increase the absorption of urea. So what happens? Urea level will increase. So ratio between urea and creatinine will be high in pre-renal failure. In simple terms, you can say the disproportionate rise of blood urea compared to creatinine. For example, blood urea may be 200, creatinine may be 2. So this disproportion, more than 1:20, that is creatinine level and urea level, if you compare, out of proportion rise of urea is an evidence of pre-renal failure. Hope this point is clear. And in patients with pre-renal failure, the urine specific gravity will be high. This is because water reabsorption is occurring. This is because of the secretion of the ADH. So 2 things in the urine that you should look for, or 3 things. One is the urine amount, second is urinary sodium, third is the specific gravity. The specific gravity increases because the water is reabsorbed. Next question is, what are the histological changes that can be observed in pre-renal AKI? Remember, pre-renal AKI can lead on to damage to the tubule. It produces a tubular necrosis. So the correct answer is inflammatory changes, focal breaks in the tubular basal membrane and interstitial edema. So mainly it produces tubular necrosis. So the point to be kept in mind, even though pre-renal failure is a separate entity, it can recover completely. If it is not corrected, this can lead on to renal failure or due to renal cause. So in the next session, we'll be discussing renal cause of renal failure. Hope it was useful. Thank you.